All right, good morning, everyone. Oh, we can do better than that, guys. Good morning. Yeah, you need more coffee. Okay, excellent. Well, my name is Roderick King. I'm one of the senior faculty at the Disparities Solution Center, and a pleasure to be here this morning. And this panel that we're doing now, what we're calling Grounding Session 4, the title is The Missing Pieces of the Puzzle, Oral Health and Mental Health and Chronic Disease Management and Primary Care. I'm joined by three esteemed colleagues. They're going to give us some insights from their various perspectives. But in particular, as I was preparing for this session, I remembered back to a comment from Harvey Feinberg. Dr. Feinberg is the president of the Institute of Medicine. And a couple of years back, there was a big IOM report on the importance of oral health. And when he announced the report, he said, finally, we're linking the head back to the rest of the body. And I think it's a point in comment because very often when we're talking about creating value, improving quality, and reducing cost, and in particular addressing disparities, we often forget about the entals, mental and dental. We sort of put those in the back burner and say, oh yeah, that's right, there might be mental health issues, and oh yeah, they might have problems with their dentition or their oral health. So this morning, thanks to the support from the DentaQuest Foundation, we wanted to have a particular conversation on how do we reintegrate those pieces. And we particularly invited the three panelists this morning to help us explore that a little further. I think what's particularly poignant about this and the timing of this is if you look at some of the issues around behavioral health, clearly we have an issue in this country around how do we take care of folks with mental health issues. If you look at the dual eligibles and Medicaid and Medicare eligibles, 2 out of 5 dual eligibles have some kind of comorbidity between physical illness and mental illness. And if you look at the dual eligibles above 80, 50% of that population have comorbidity with mental health disorders. And if you look around, and currently with our sort of setback that's happened to our country financially, that has only exacerbated a lot of the challenges around behavioral health and mental health issues. Oral health, the same way. Currently, although we made some progress in oral health and dental caries, or what we often say early childhood caries, still 80% of the disease exists in 20% of the kids in this country, and those primarily are children of color. So, how do we begin to have this conversation of not having isolated discussions on oral health, not having a discussion just on behavioral health, but actually health for all and improving value for all and integrating all three of these pieces? So just by get a sense of who's in the room, how many folks currently are oral health providers? Okay, so as we suspected, Brian is the only one. All right, so that in itself is very telling. So if we're talking about addressing disparities and we have one oral health provider in the room, we have to figure that out. And by the way, as a sidebar, the announcement about this meeting went to the ADA, went to the local oral health coalition, so it wasn't due to a lack of dissemination that they aren't in the room. Follow up with that, how many folks are behavioral health or mental health providers in the room? So 1, 2, I see 2 hands. 1, 2, 3. So again, fairly large crowd, but you're only looking at 3, maybe 4 people in a room that provide behavioral health services to our population. So you see that although this is a critical issue and clearly is gaining enough traction, there needs to be more folks that are involved in these areas as part of this discussion around equity and quality if we're going to provide value for our patients. So the one thing I will leave, because I'll lead off before I introduce our panelists, is that this is a critical time. You've been hearing from yesterday, you've heard from this morning, that with health reform and the transitions that are happening in healthcare, this is really a transition point, a point where we're changing the way that we're looking at providing care, delivering care, how we're paying for care, et cetera. But the point that I really want to emphasize is that we have this 2 major issues. One is we have not figured out as a country how to provide and pay for behavioral health, and we're struggling with that. So as we think about redesigning payment systems, clearly something that needs to be taken into account. At the same time, as one of my colleagues raised to me the other day, right now in this country, we're about to face a large number of baby boomers that are about to retire. And most of those baby boomers, if they're employed, actually have their dental services through their employment. And once they leave, will not have that anymore. So how, as a society, will we begin to think about taking care of the oral health for these populations? So I don't want to go into too much more because I know Brian and the others will share more about it. And right now, I'd like to turn it over to them. So starting first with my immediate left, your right, is Dr. Brian Swann. He's the Chief Dental Officer at Cambridge Health Alliance, and I've asked him to talk a little about the Alliance and what their vision was and sort of what some of the challenges have been around addressing oral health and improving oral health for populations. Next to Brian is Dr. Octavio Martinez. He is actually, how long have you been there now, Octavio? 4 years. Wow. 4 years, the executive director for the Hogg Foundation for Mental Health from Texas, and has been doing great work. And I asked him to talk a little bit about a recent report that came out from OMH around looking at behavioral health disparities. And then also, in the very end, Dr. Tamarah Duperval-Brownlee. I'm still trying to get used to that. Yeah. I knew Tam before she got married, so I'm getting used to the hyphenated last name. And we've asked Tam to come and share. Tam is this Chief Executive Officer and the Chief Medical Officer for Clinical Services for the Lone Star Circle of Care, one of the bigger FQHCs in Texas, and to talk about her experiences of how they've strived or visioned or created this integration of primary care with behavioral health as well as oral health. So with that, Brian, I'm going to turn it over to you to kind of give a little context for the audience around what's happening around oral health in our country, disparities, quality. What's some of your thoughts?
Well, first of all, I want to thank you for inviting oral health to this forum. And as you've already indicated through the audience, we always are underrepresented. 93% of all oral health providers are in the private sector, and very, very few are policymakers. Only 3% of oral health is done in the public health sector, and another 3% in the military. So we have been outliers for quite some time. And the reason I'm here today is because I was invited to be a part of a fellowship that all of us were a part of, because I wanted to see how policy was done and understand the nomenclature of public health. And in the private sector, treating patients as a clinician, I didn't understand that. So this was an opportunity to bring that experience to the table, and it's been extremely valuable. So I've become an advocate for oral health. And the difference here that we're talking about in dentistry and oral health, and I need to take a moment to explain to folks about what that is. Most of us think about dentistry in the context of teeth. So if I came to a session like this one and introduced myself as a dentist, half of you would turn off and just think about your own personal experience, because pretty much that's all you have when it comes to dentistry. But dentistry, what we say in the field, is really the technical aspect of dentistry. It's the drilling and the filling. It's supportive tissues and things that are actually going to be generated to make money, because dentistry today primarily is a business. And it is the business model that has been running our profession for quite some time. But based on the heels of primary care, this is an opportunity to change that perspective. We need to start thinking more about oral health and looking at the entire body. So our concern should not just be the whole, but it should be the WHOLE body. We need to start looking at it from that perspective. The Cambridge Health Alliance, where I work, is the safety net, major safety net organization in the state of Massachusetts. 3 years ago, we had 3 dental clinics that were in 3 locations: Somerville, Everett, and the city of Cambridge. Because oral health was losing money in the transitional stages between mass health, what we have today, and what was previously there, the centers, the organization felt that they needed to make changes, and so they cut oral health down to 1 clinical site. It was interesting that when the administration came back from the town hall meetings that they were having, they all came back scratching their heads saying the same thing, and that was, I'm so surprised that the public wants to keep oral health. But what we found out is that globally, in the top 3 demands from public, from lay people, oral health is always in the top 3 in terms of what people would like to have relative to their healthcare treatment. We're also taking the opportunity to call ourselves oral physicians. We have a bill in the State House, has been there for 7 or 8 years, and we've always gotten shot down by the ADA in calling ourselves that, and their rationale is because it will confuse patients. They won't be able to understand what's the difference between a dentist and an oral physician. Well, that confusion might be a little bit healthy, because what we're saying in being an oral physician is that we are trying to incorporate more primary care in the scope of the dental practice. You take institutions like Harvard, which is the first dental school created in 1868, 67, that had a university setting. So in other words, they created the DMD, the Doctor of Medical Dentistry. And that meant that they trained for 2 years in the school of Dentistry or School of Medicine together, which they still do. So for the first 2 years, dental and medical students are all considered medical students. But if you ask a medical student in their 3rd or 4th year, what do they know about oral health? They will tell you, I only know what I experienced as a patient from my own personal dentist. If you ask dental students, what do you know and how are you going to incorporate the training that you have in medicine into the scope of dental practice, they said, well, nobody gave us a clue about how to do that. All the case studies that we saw in the 2 years of medical school were only medical. There was no correlation between dentistry. Well, that is just beginning to change. But this is talking about more than 100 years of being taught the same way. And when I meet prominent professors, medical doctors from Harvard, and they're around the country now talking about primary care, and when I raise that one question, what do you know about oral health? They all draw a blank and say the same thing. I remember that I had some dental students in my medical school class. I think we were in class for like 2 years together. And I said, well, what did you do with that? I don't know, we didn't do anything with that. So this is a dilemma that we have. When you start thinking about whether or not caries, dental caries is a disease. We don't think about cavities as a disease. Periodontal disease we think of, but we don't think about decay as a disease. Can it kill you? Does that make it more important because it can take your life? Well, it can. The Demonte Driver bill that's in Congress now, advocating same things that Affordable Care is advocating. More access to care, more providers being trained, but providers being trained with a concept of primary care and how we as oral health care providers can play a part, as we should play a part in that role.
Brian, could you talk a little bit about Diamante Driver? Because I don't know if everyone in the room knew about his case.
Diamante Driver was a case that took place where a 10-year-old died from dental decay. The irony in that is that it was in the city of Baltimore, right next to our nation's capital, a family that was on Medicaid insurance with 4 or 5 children. Diamante's driver had an abscess from tooth decay. His mom went to 20+ different dental offices and was either refused treatment or told to come back in months from that time. Patient had swelling, had pain, had inflammation, had exudate coming out of the abscess, and no one would treat them. And she had insurance. So when Diamante also developed a dental abscess from tooth decay, the mom assumed that she wasn't going to get much service and waited and hesitated. And finally, when she went, one dentist agreed to see the boy, but he said he would fill 1 tooth at a time, 1 appointment per month. The problem got worse. The abscess led to bacteria on the brain. After a couple of operations, Diamante died. And that really caused a lot of friction in the city of Baltimore from the mayor, the governor, and from congressional people alike. They were embarrassed that this would happen in our own nation's backyard. This is not just happening in Baltimore. This happens in other cities. This happens globally. Dental disease, dental caries can take your life. So the other thing is important to understand that dental disease, whether it be from tooth decay, periodontal disease, the value of it is not only the fact that it helps you in terms of masticating food, in terms of your appearance and chewing and so forth, and talking and swallowing, all those other great things. It also is a risk factor for communicable and non-communicable diseases. Periodontal disease, for instance, is created from stress. Stress alone can have an effect on the gum tissue. It's created from poor hygiene, aging, smoking, alcohol, nutritional aspects, systemic diseases, hormonal changes, HIV/AIDS, and mouth breathing. All of these things and more can create periodontal disease. The mouth is basically a window to the body, and by looking through it and understanding what you're looking at can give you clues about what may be happening in a person's overall body. When a person goes to buy an animal, a horse, whatever it might be, the things they look at first are his nails and the mouth, the dentition. And also as a risk factor, we already know the science is there, that it proves that there is a correlation at least with diabetes, with high blood pressure, with heart disease, lung disease, including asthma, low birth weight babies, preterm delivery, and in one study in Australia, erectile dysfunction. The whole mental-dental aspect and that combination is interesting too. Mental health is associated with helping people to overcome phobias and pain. Well, everybody thinks about the dentist as a painful person. I mean, we have a huge suicide rate among dental professionals, and at one time we were the top. And guess who we shared that slot with? We shared it with psychiatrists.
Psychiatrists, yeah.
Now, I think we're down. I think we're down, but you know, the issues of internalizing what people bring to you, their problems, their pain, the stress factor and how it plays out in today's society, and particularly with nail biting and adult thumb sucking, grinding of teeth, ulcerations that are created from stress, herpes simplex, another one that's created from stress. Pain is associated with perceptions. That's a study that's being done that says that when a woman gets an injection, some women almost equate that to rape. And when men have teeth removed, the perception in some is the same as castration. We're also looking at orofacial proximity to the brain. When you have something that's going on in the mouth, it is right close to the central nervous system. Tooth grinding affects your joints, your TMJ. That's transmitted to the cervical chain and the lumbar area. About 8 years ago in Iraq, the number one non-battle casualty was oral pain. More people came off the front line for dental pain than any other particular ailment. But the interesting thing is that the rate was somewhere over 50% of the non-battle casualties had to do with oral pain. Mm-hmm. That gets into a whole other issue of quality of care and what we're giving to our military personnel. And then we're sort of missing the boat. James Marks, the former director of the National Center of Chronic Disease and Prevention and Health Promotion, said that no important public health problem in our times can be solved by public health, clinical, or research alone. Chronic disease and their risk factors are interrelated with many forces affecting risk. So here in the state of Massachusetts, where 30% of your senior citizens over 65 32% do not have teeth at all. 20% of your seniors haven't been to a dentist in 5 years. 60% have periodontal disease or current decay. As Rod said, 80% of that population has one chronic disease and 50% have at least two chronic diseases. Arthritis, the ability maybe to even brush your teeth, is the number one physical disability. And many of our seniors don't have dental insurance or access to care, even if they do have insurance. This is the perfect storm for adding to the problem of chronic disease. You combine that with the fact that 27 states in our country either have limited or no dental insurance. Mass health has changed to the point where emergency services can only be done in the private sector and restorative services can only be done in the clinics. And how many clinics do you have to serve over 800,000 adult people? So when they are coming into your ED departments, your ED docs aren't really trained that much to do oral treatment. When they go to the emergencies that are in the private sector, they can't restore their teeth. So if pain is that great because it's this close to the brain, that person usually elects to have that tooth removed. There's no Medicare. Medicare has no dentistry. Your ACOs don't have dental benefits. And over 130 plus million people in this country don't have dental benefits. And is dental benefits really an insurance? No, it's a benefit. It's not really an insurance. And with 93% of all of our workers in the private sector, we just have very limited representation at the policy table. So I will finish this up just by saying that here are at least what are some of the solutions that are being worked on, either the Cambridge Health Alliance and other venues. The number one childhood disease globally is dental caries. Dental decay on children is the number one childhood oral disease, but it's preventable. It's preventable with preventive measures. If every child had sealants placed on their first permanent molars by grade 1, and sealants placed on their second permanent molars by grade 3, we would change the whole complexion of how many people have teeth removed. It's horrible to take a pair of pliers on a child that's 12 years old and pull out a tooth that has roots that could be a ½ inch long or more, where bone is tearing. Did you think that person would ever want to come back to a dentist or to anybody again? Access to care is an issue. One of the models that we're working on at the Cambridge Health Alliance has to do with shared dental appointments. We borrowed that from medicine. So what we do with pediatric patients, we bring 10 families in at a time. And we orientate them together, we do lap exams together, and we provide fluoride varnish together. For people who are getting their teeth pulled out, they need to wear dentures. And adults can come to a clinic, hospital-based or community-based clinic, and we can restore what's missing by making dentures. It was taking too long, and we were losing money every time we put in a denture in a patient's mouth. We've created a model, again using the shared model from medicine, where we see 10 denture patients in a conference room together. With the exception of their initial examination appointment and their last delivery appointment, we see all of them together. The stress level is greatly reduced because they are sharing this with peers. They've signed a confidentiality statement, and we've gone from taking a loss to making a profit with dentures paid for through Mass Health. Curriculum changes need to be initiated in almost every medical and dental school in this country. I only know 2 examples, University of Washington and some other school, where actually have oral health in the curriculum for medical students. If you don't put it in the core curriculum, it's not going to stick. To ask physicians to do fluoride varnishes, they're not going to do it. It takes time. They already don't have enough time with their patients. Maybe auxiliaries would do it. We have to look at that as a model as well. But if physicians are trained about the value and importance of oral health in their core curriculum, because physicians outnumber dentists in this country 5 or 6 to 1, and more of them are at the policy table, we would not be left out. It has to be valued. We need to cross-train our residents, especially those residents that are in family medicine and primary care. Dentists need to be in your EDs. And if not, your EDs need to be trained about how to do oral health. When your family docs come to our clinic, one of the first things I'll let them do after they watch for a while is do an intraoral injection. I just want them to have to say that they've done one before. The Affordable Care Act supports most of these things. And I'll just leave with one quote by Galsworthy that says that one's eyes are what one is. One's mouth is what one becomes. Thank you.
Great. Thanks, Brian. You know, and I think, yes, absolutely. And your points are so on time. And I think, you know, particularly, I've now had a chance to travel around the country and seeing 18-year-olds, where 50% of the 18-year-olds in a county have lost all their teeth. Mm-hmm. I mean, this is a travesty. And what people don't understand is it's not just a cosmetic thing. Because if you fast forward, how will those kids get a job? And if you look at dentition, that's one of the key factors of what prevents people from getting a job. They just have bad teeth. So I think, you know, we're at this critical time where there's a lot going on from leaders like yourself and others on how to integrate oral health into what's going on. And yes, there are some cultural challenges, shall we say, because dentistry, if folks don't know dentistry very well, is a very different industry than medical care.
Absolutely. And with children, 52 million plus hours of school time is lost every year from children suffering from dental pain.
Right. So there's no issue with defining the problem or a problem statement. It's now, what do we do about it? And similar to the healthcare side, innovative strategies have to start to be created, whether it's seeing groups in block and signing confidentiality documents so that there's a sense of safety, whether it's training auxiliary workers to help provide some of those varnishes or sealants, whatever the case may be. Absolutely. But again, thinking outside the box, because the subtext, if you didn't get it from Brian, the subtext is that this is an issue that predominantly affects people of color, without a doubt. Obviously, it's a bigger population, but it's worse in populations of color. So, and from the context of equity, it's a huge equity issue. And one of the reasons why I personally have dedicated a good part of my career of working on this issue and trying to figure it out. It's sort of the stepchild, but now a vital component. And I know, talking from the payment side, there's this big concern about how you're going to pay for this.
Right.
You know, as we move to exchanges, there's a lot of debates on will there be dental insurance provided in exchanges? And at the same time, states are scaling back dental services at their state level through Medicaid. So, but thank you, Brian. Very, very pointed piece. So let me shift gears a little bit and move to you, Octavio. Unfortunately, behavioral health is not in any better situation than oral health.
Not much.
And but I know you've been doing some great work through the IOM. You also were part of a great committee that did the OMH study looking at disparities and integrating oral health and primary care. Mental health and primary care, excuse me. But why don't you share a little bit from your context? Because you come from a very unique perspective where you're a psychiatrist, but at the same time, so you've had that clinical experience, but at the same time, now you're at a very higher policy level. And as a foundation leader, you have this leverage of how do you kind of move this agenda forward. Right. So tell me a little bit more from your perspective.
Thank you, Rod. I also want to thank the invitation to be here and to share a dialogue with everyone here. And also, I'll touch upon what Brian has brought up, which is really key, is the mental-oral sort of connection. And obviously, the connection I want to make is, and Dr. Satcher, as well as the World Health Organization, has said many times, there is no health without mental health, and I would say there's no health without mental health or oral health. Mm-hmm. It really is a holistic approach we must take. And Brian mentioned that I'm from Texas, so to sort of, let's get rid of some of the misperceptions you may have about Texas. At one point in time, Texas, in fact, actually was a little bit more progressive than it currently is. And so the Hogg...
The great state of Texas.
The great state of Texas.
Okay.
The Hogg Foundation for Mental Health, I think, is one of those lasting sort of additions that comes from a time when Texas was progressive. We're now been around 72 years. Back in 1940 was created by the Hogg family. And as you can imagine, the majority of that wealth was created by oil. And so we're a great benefit from that. And so what's interesting about the Hogg Foundation for Mental Health is it's autonomous, and yet we are part of the University of Texas at Austin. But our charge is actually improve the mental health for all of Texas. And so it really allows, as Rod was saying, a really great ability to try to influence policy for such a large state. And by addition, as well as by invitation, able to as well share with the rest of the country. And so getting to the report that Rod was referring to, let me give you a little bit about the rationale for the report, which is enhancing the delivery of health care, eliminating health disparity through a culturally linguistically centered integrated healthcare approach. So all of those are really key words that we took a lot of time, as you will, those of you that worked on reports, we go back and forth on what words to use, because we really wanted to convey this sort of really integrated model, but how in fact, what we had noticed, and OMH brought this to us, to the Hogg Foundation, because of the work we've been doing in integrated healthcare since 2006, is to really bring to the forefront again, let's not lose what we've been doing in this paradigm, this rubric of cultural and linguistic competency, and now we're hearing integrated healthcare, and yet the two seem to not, that Venn diagram wasn't intersecting as much as we wanted it to. So we're hoping to bring a report out there to bring it back to the forefront and realize that in fact, cultural and linguistic issues are front and center, and really when you think about patient-centered, and when we think about it, especially from the rubric of us as providers, that first we should do no harm, I would say, and one of the reasons that we presented this to the OMH and that they agreed to fund us on, is that if we in fact don't understand our patient, understand our community, and don't bring those issues to the forefront, we in fact are doing harm. So that was part of the rationale. It's also given in the fact that Rod gave some great numbers when it comes to mental illness and the prevalence and incidence. But also, as we well know, and maybe you've heard, or you should have, is 1 in 4 Americans at any one point in time is dealing with a mental health illness issue or a mental health issue. And then you take into consideration that most individuals prefer to go to their primary care doctor, and especially individuals of color. They're not going to, quote unquote, the behavioral health specialist for substance use and or for mental illness purposes. Then you lay in chronic disease, and I would venture to say, being that we're all emotional beings, that in fact, I would challenge anyone to tell me that there's not a physical ailment that doesn't have a behavioral component to it. Even the common cold. What do? We regress. We want to have chicken soup. We want mommy to take care of us. Those are all behavioral issues that we're referring to, and yet it's this little bitty virus that's taken over our body for a short period of time. So those chronic diseases, the ones that really come to the forefront are obviously heart disease. There's great studies now that show the interaction between depression and the myocardial infarction and vice versa. Diabetes, the same kind of sort of dynamics are affecting us. Pulmonary diseases, think about COPD and anxiety disorders or panic disorder. They can come from the fact that you can't take a breath or loss of breath. Not to mention also something, say, not as common yet, but equally, I think, affecting certain populations like lupus. Now, why would I mention lupus? Why? Because one in about 1,000 non-Hispanic white women are affected by lupus. But actually, it's 1 in almost 250 for African-American women. So this chronic illness really affects a lot of women, and especially women of color, those of African-American. So if thinking about lupus, and then the other thing you need to know about lupus, which I think is rather interesting, why I bring it up, is that often, in 80 to 90% of cases, it's actually the behavioral health symptoms that present before the physical ailments. So before you see a malar rash, women will present with depression and/or they'll have confusion and things of that nature. Mild and subtle, so where they're going to go? Probably their primary care doctor. With those symptomologies, at least in our current system historically, they would be referred then to behavioral specialists. But imagine if actually we were an integrated approach and they were all in the same place, how much better we actually would be able to take care of something of that nature. And that's happening and has been happening, and hence with the reason that we really wanted to address this issue. Now take a look at those with severe mental illness. 2006, the National Association of State Public Health Directors, NASHPD, did a study that they put out. What was really groundbreaking and landmark about this study was the fact that it showed that individuals dealing with severe mental illness, i.e. those with schizophrenia, bipolar disorder, and major depression, on average, their lifespan was shortened by 25 years. That's a lot. Texas was one of the states that participated in the study. Not to be outdone, we were over 29 years. So if you have a severe mental illness in the state of Texas, practically shaved 30 years off your life. That is a travesty, especially in a country as wealthy as ours, and especially in a state as wealthy as ours. The state of Texas has a $1.3 trillion, yes, trillion dollar economy. Only second to California, who has about a $1.8, $1.9 trillion dollar economy. So it is not a lack of money, but in fact, it's really prioritization and coming up with a much more efficient and effective system for all of us. So those were the rationales of why we thought we needed to put this study out. In November 2011, we brought together a consensus of individuals from across the country. Now, what we want to do is bring some experts in different fields, and we concentrated on, obviously, integrated healthcare, as I mentioned. And so we had Jürgen Unzer from the University of Washington, who very much has developed the collaborative care model. And that model is very integral to addressing integrated healthcare, has a lot of key components. He was at the table. We had also, especially folks from the community, because we wanted representation from Native Americans, from Asian Pacific Islanders, from African Americans, and obviously Hispanic and Latinos. So we reached out to communities across the United States to bring them together. Folks coming from Chicago, from New York, from Boston, obviously from Texas, from Seattle, California, Ohio, Illinois, Indiana, you name it. We brought folks key together that we found were exemplars of what they were doing in their community mental health centers, in their FQHCs, and in even private clinics, and brought them in to be able to share with us and for them to have a chance to really come together and decide what are the key components of integrated healthcare and what should we come up with. Well, what they came up with, which I thought is really interesting, because you take yesterday and even this morning, and you take a lot of those key components that have been discussed, that's what these communities want as well. And what they come up with is an indicated care organization. And what this organization really should be is, and they should always have been, is considered a member of the community. So what does that mean, to be a member of the community? Well, it means that they care about their community. It means that they are willing to understand who the community is. And one of the things that they put forth that they thought would be excellent for integrated healthcare organizations to have is obviously to have a learning community as well. Because not only should they understand social determinants and what truly is impacting our health and our health access and the way we actually see the perspective of health and how we define it, but in fact, there should be a garnering and there should be a flow of information going back and forth. The integrated organization should then be composed of an integrated care team. And that includes everyone should be on the team, including the front desk. How often have we encountered, regardless of where we go, that the front desk can actually be quite a barrier if we're not attuned to that. But the integrated care team would include is interdisciplinary and would include some folks like Brian and folks like Tam and also pediatricians like Rod. And also that there is no single door is the wrong door. Every door is the right door. Because it could be that if you have an integrated care team, actually the oral health physician may be the one that actually identifies that this person actually maybe has alcohol in the breath. So maybe substance use is something that ought to be addressed, and they can bring that to the table. The integrated care team, what they would want, the consensus was that there should be one history, and that's where the information technology becomes so key, and where it can really be, I think, a lever to achieve that. To have one history, which then would result in one treatment plan. Now, obviously, we know that this is what we're hoping to achieve, but that ought to be the goal. Much like what we do when we do strategic planning, we need to determine what is the goal that we want to have, because the outcome that we truly wanted was obviously improved healthcare for all and actually an improved healthcare for the community. And the consensus team this is what they developed. So I encourage you to take a look at it. It's out there. It's on our website, the Hogg Foundation. You look it up, and bam, the consensus report. You can click on it, and you can see further. Because there's some examples that we have placed in there of exemplars throughout the community, like Project Brotherhood out of Chicago, where they, in fact, what they did was they actually took, and some of you may have heard of this concept of actually, they hired a barber, they trained him in mental health. And so when he actually is interacting, and of course this is mostly with African-American males in the Chicago community, when he's interacting with them, he actually can elicit much more information than probably even a doctor can. And it's an amazing thing, but get what? He's part of the integrated care team, and he's able to share that information. And it's a wonderful way for us to also think about the community itself should be is an asset-based entity in itself. And many of the solutions that we're looking for some of the sort of challenges we've been discussing can actually be out in the community if we're willing to bring them in. And the other thing that I'd like to mention is the Connecticut Latino Behavioral Health System. Now what they did was they came with a cultural linguistic competency index for their providers. So this is, I thought, really quite interesting and quite fascinating to me. So what they do is they're training their providers in cultural linguistically issues, especially Spanish language, to be able to address their community, because when they did their environmental scan, the majority of their community is Hispanic and Latinos. So this is another thing, is tailoring things to who your community is. What they were able to do is, which I thought was, like I said, was really fascinating. Not only did they do training, they do pre and post testing of them. They also asked them how did they think the training went. They asked their consumers also after they've seen their providers, how they think things are going. And those are pretty common. But the other thing that they've also instituted is, which comes from the academic center, I thought, wow, we do that in psychiatry, that's kind of cool, is the fact that actually with the permission of the provider as well as the consumer or i.e. patient, they actually also tape sessions. And then they use the tape sessions to go over with their providers to find out the gaps that they may have in the delivery of culturally linguistically appropriate and centered care. So they're not using it to ding them, they're using it to actually improve things. And when you have that kind of environment and you have that kind of buy-in and when you have that kind of leadership, you can really make a difference. And also the other thing I would like to mention, I think Brian brought up, is he mentioned a bit about workforce. And it's one thing that I really haven't heard a whole lot yet at the conference. And so I also want us to really be thinking about that, and especially from the fact of when it comes, as Brian mentioned, for oral health providers, but think about the deficits that exist in mental health providers. And hence the reason we're really having to think and be thinking outside the box, who can we bring in? Because there's no way, if you think about how long it takes to train us, that you're going to actually be able to meet the deficits that exist. And some of the deficits are really quite dire. In the state of Texas, when it comes to one of the metrics is, how many physicians or providers per 100,000, we're like way down when it comes to just psychiatrists, especially if you start to think of child adolescent psychiatry and geriatric psychiatry. But it even gets worse the closer you get to the Texas-Mexico border. And I would imagine those statistics are the same for Arizona, New Mexico, and California. The closer we get to Mexico and the populations that live there, they in fact are having kids whose entire teeth are being pulled before they even hit high school. And think about the pain and the trauma that it goes with that, and it is having a behavioral health impact on these individuals. And so trauma-informed care, which is another very important aspect to what really to bring forth into integrated health care, is key and center in respect to some communities of what's happening. With that, I'm going to leave it there and turn it back over to Rod. Okay. There's some other things I'd love to mention, but I want to hear from Tam as well.
Great. Thanks, Octavio. They each had a wealth of information, and I promised them that we'd have a conversation, so more of it would come out. So hopefully you guys have some good questions, and that'll come out. And thanks so much, Octavio. I love the example about the Chicago program. And for sure, I share more with my barber than I do with my primary care doc. So
it's amazing.
It's such an easy, simple solution. And he's got me there for 20 to 30 minutes. So
right. You're a captured audience.
I'm a captured audience. So, but in that, as we were prepping for this panel, one of the things, as you know, is the conference is focused on action, is trying to find exemplars in the field. And I called my colleagues at HRSA. I said, you know, anybody doing some really interesting work that's integrating oral health and behavioral health? Mm-hmm. And they said, well, I'll get back to you. And in my conversation with Octavio, he said, oh, I know who you should ask. Let's ask Tamarah. Mm-hmm. So Tamarah is the CEO, as I said, and the Chief Medical Officer for Lone Star. So why don't you tell us a little bit about some of the interesting things that you've been doing and some of the challenges of trying to integrate these pieces, because clearly your organization is on the cutting edge. And people are still grappling with it, but you guys are really doing some interesting stuff. So share with us.
Thanks. I'm really excited to be here this afternoon or morning and to be able to speak with you about what's going on. And I promise I won't hold you long because I really would like to hear what you think about it. But we're one example, I think, of what's happening in the nation of practices who are taking care of great populations to really make sure that the care we delivered is truly integrated, that the head is connected back to the body, that whatever drips down from here is really taken care of in that respect, both in oral health and in mental health. So being a good family doc trained in the right way, I'm going to tell you what I'm going to tell you, and then I'm going to tell you what I told you so that we can facilitate the conversation in that regard.
Excellent.
So I'm going to tell you a little bit about Lone Star. And what we've been able to do so far, how we're going forward, and then particularly spend some time about challenges going forward into the future for your consideration. And I'd love to be able to hear about perhaps solutions, so that we can address together, knowing that some of them are environmental, of course, being from the great state of Texas, but also realized nationally as well. So Lone Star is a federal qualified health center. It's about 10 years old. And it's been an FQHC for about 7 years. And it was started in Georgetown, Texas, a suburb, if you will, of Austin, by some concerned individuals, like most stories of community health centers, of people who are really tired of seeing bad outcomes. It actually started with a principal in a school who was seeing kids not showing up because of preventable illnesses, ambulatory sensitive conditions that were being treated in the ER, oral health, being a part of it. Forget about mental health. If they could recognize it, they didn't know what to do with it. So they're like, we need a model to be able to do this. So they started off with a free clinic, a community clinic, and got a board together. And their job really was to write checks for sustainability. And by month 3, they realized they couldn't write enough checks to keep it going. And so in their plan for sustainability, they went on to be an FQHC. That was 10 years ago. They continued to grow for 3 years as they were waiting for designation. And after the designation, that's really when the explosion happened. It also was concomitant with the work really under President Bush. It was mentioned yesterday for expansion for community health centers throughout the nation. And Lone Star was primed for that, given the geographical area that they were taking care of persons. We now are 26 clinics in 17 locations, and we have all the service lines that FQHCs are beholden to be able to take care of: family medicine, OB, behavioral health, pediatrics, dentistry. We also have a line for adolescents, senior, vision, and a couple of Class A pharmacies. We've been able to achieve Joint Commission accreditation, patient-centered medical home from NCQA level 3, and we play with 3 hospital systems that normally don't play well together, and that's really for sustainability. We have 130 providers. We take care of approximately 100,000 people in Central Texas in 3 counties, soon to be 4 counties. And we look like all community health centers throughout the nation. We have about a third that are completely uninsured, really a little bit more than that, but no coverage whatsoever. 50% Medicaid, 5% Medicare, 10 commercial, and the rest are other, which could be covered by indigent programs in various counties, but otherwise, could be mixed in that regard. What's also peculiar about Lone Star is that, unlike other community health centers where a large part of the operating budget is funded by federal grants, we're less than 5% for federal grants. Really, most of it is patient revenue And a good chunk, 22%, is actually by private partnership with those 3 hospital systems that I was telling you about. And it really has been the way of being able to provide sustainability for programs like in mental health and oral health, talking more on a 30,000 level perspective about sustainability and really being able to articulate the case of treating the whole person, W-H-O-L-E, and being able to deliver good outcomes. And I think those accreditations tend to talk about it. And we provide the services, as I mentioned, like other community health centers. We're open 6 days a week. We have a robust patient navigation center that's solely dedicated towards patient navigation throughout our system. If it's primary care, specialty care, they're open 7 days a week. They answer questions. They're fully integrated with patient service representatives as well as clinical folks. So they are doing reminders for well child visits, and you missed your behavioral health appointment. We do proactive campaigns for certain times of the year, so those well child visits or whatever conditions that the care team would like to be able to push out to our patients. I think another great thing about what we've been able to do in a short period of time is really embrace health information technology. It's helpful that our CEO came from the technology and credit card sector, so he brought in a different perspective altogether about how we should be integrated and be able to communicate throughout our vast network and enterprise of care delivery. We span 70 miles, in terms of our care delivery, where our clinics are, and we want to make sure that a patient who enters our door, no wrong door, if it's for oral health first, if it's for mental health first, if it's for medical, that they are getting the same message, same drumbeat from whether they're in South Austin all the way up to Temple, which is about 70, 80 miles, that we care about you and you're getting the right care, right place, right time, and we know who you are. You don't have to repeat your story no matter what you come in for. With that, we've been fully integrated with the electronic health record from the beginning. We participate, as I was mentioning yesterday, in our local HIE, and we have quality and operational dashboards up the wazoo that at any given moment live you can see performance measures as well as operational measures. I mentioned all that about Lone Star because it's important to understand the context of why behavioral health and oral health were important. There are program requirements, true, but also we are realizing that in the beginning for Lone Star that 30–40% of our patients that we were taking care of had concomitant comorbidities with mental health disorders. And frankly, I don't think providers really knew what to do. I think as primary care providers, particularly in family medicine, you kind of know and train that, yeah, it's probably going to be mental health first before the physical comes out. If not, they're interrelated, so you have to be sure to do the screening while there, and we're very good about training our providers in doing that. But it was clear that we were going to need a bigger boat pretty quickly to take care of persons who are also offloaded and weren't able to be cared for by the local mental health authorities within Central Texas that were now relegated to 3 conditions. And if you've ever seen a DSM-4R, it's this big in terms of mental conditions that need to be treated and that we see in the primary care line. So we started off with behavioral health actually in 2006, one psychiatrist, and he got busy real quick. And we got advice about don't do it, contract out, work with your MHA. And so that was just enough impetus for our CEO to say, yeah, we're going to do it then. So we took a leap and we made an investment and we pleaded the case as well as presented data about the comorbidities, about the disparity of persons getting their care in the emergency department for ambulatory sensitive conditions, and the difference that a community health center can make in actually decreasing those ambulatory sensitive conditions being treated in the emergency department. One example is with our location in South Austin, where we decreased, just by being 300 yards away from an emergency room, extremely busy, their ambulatory sensitive conditions for our mutual patients by at least 30% and being there a year and a half. So it was impactful. So one of the local foundations said, yep, I believe in it, let's give you some seed money. And with that, we created a sustainability model where we managed mix as well as the portfolio of providers who delivered care. So a combination of having psychiatrists who are anchors, not only doing med management, but facilitating conversations with the medical side, and also a group of therapists to take care of our patients as well, knowing that a lot of the care is beyond medicine. that you can take, but it's also the cognitive behavioral therapy that needed to take place as well. So today we have 16 psychiatrists, and they span from geriatric to child and adolescent psychiatrists. We unusually have like 5 child and adolescent psychiatrists, which is huge for one organization to have, and a core of 26 therapists to take care of our patients throughout. And we still have a lot of need, and they take place in the form of embedded therapists within the clinic. So in a primary care office, for example, in family medicine, where there may be 6, 7 providers, there's a therapist right there, so that if we have mutual patients or a day for a crisis, I can just walk over and say, hey, Octavio, I need you today. I need you to establish some care with this patient. This patient can't wait to get plugged in for 3 months, to go see someone. And they're right there, and it facilitates great conversation, as well as a comfort level in reducing that stigma, because when that person is entering my office, they know I'm being taken care of in my health home. It's medical, it's behavioral, and then now the oral part of it, again, a program requirement for community health centers is to have an oral health program. So we started that program from the very beginning. It's about 8 years old now, and we have a core of about 11 providers, dentists and a few hygienists that provide care for our patient population. And because of the nature of how oral health is covered, I think Brian covered that very well. Adults pretty much are out of the equation. If you are an adult in Central Texas and you don't have private insurance, you can forget about it. There is nowhere for you to go. And the amount of, again, ambulatory sensitive dental conditions that could be served that are seen in emergency rooms are huge. They're coming to primary care offices, and we experience that lack and disconnect of information and cognition of how to deal with these issues. So we want to be able to provide that. So our dental program is largely an adult program, but we've realized, of course, that family or patient-centered model, we really need to make sure that the whole family is taken care of as well. And in order to provide sustainability also in the long term, we call dentistry our mission line because we absolutely make no money of it. And for an organization our size that has an operating budget of about $70 million, we lose $1 million just on dental alone, and that we provide for the patient population. Now we do sliding scale, blah, 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 but yeah, good luck recovering, any of that. But we know how important it is, for people to be able to get that care. Some of the things that we're looking forward to in the future is embedding actually dental providers within our primary clinics, just like mental health, so that doing simple things like providing the sealants and doing varnishes and things like that can actually be done not only by the hygienist, but allied health within the medical field. And then there's a touch base by a mobile dentist who can actually do that as well. Telemedicine is another thing I could talk a lot about, but there are challenges there with regards to reimbursement. And more about challenges, workforce. We're down at least 600 PCPs just in Central Texas alone. We're really concerned about what's going to happen in the future. I think that community health centers are well positioned, of course, to provide this integrated model. But if we don't address this workforce issue quick, fast, in a hurry, we're going to be in trouble. Sustainability, again, it costs to provide mental and oral health services to this population, and we need to be a bit more creative and plucky in terms of how we actually do that in a sustainable way. Our private partnerships have really helped with that to provide seed. I think that in having more conversations like this, though, and speaking to the integration, really making a difference in outcomes overall will definitely make a difference. So thank you. I'm going to stop here.
Okay, great. Thank you, Tam. So questions from the audience. I know you guys are curious since there's only one dentist in the room. Yes, Zoila. Mind using the mic? Yeah.
I have questions for everybody, but I wouldn't be greedy, and so I'm just going to focus on one particular question because it's something that has been dear to my heart, and specifically, Dr. Swann, in terms of dental practice. Our challenge here in Massachusetts specifically, and I think is nationally, it really is the structure of the practice of the dental system, and that is that it is a private practice, and that we have a smattering, really almost no private dentists who are really willing to accept public insurance. In Massachusetts, as you know, we had a lawsuit by advocates to try to deal with that. And so it's hard enough to deal with the fact that public insurance doesn't adequately compensate, or that there are not enough individuals who can cover, or that elders are not covered. But beyond that is this real barrier from the profession about being licensed in a state but not being willing to accept public insurance. How do you think we can move the policy forward on this within the context of the Affordable Care Act?
Well, I think there's a lot of things that you've said here. In terms of moving the agenda forward, it really takes education, and education not just of the public in terms of preventing problems, but education of the people who make policy and our politicians. They need to take a course on what oral health is and how it interrelates to the total health, to be able to really appreciate it and not just make decisions based on their own limited experiences. I think that the picture is much bigger than that. So most dentists in the private sector, when you had the lawsuit, even with the lawsuit and a dentist going out, trying to encourage the private practitioners in this state, which you have about 6,000 of them, they were asked to treat mass health patients. And after 2 years of that type of walking around and legwork, you had about 700 or 800 of them who agreed to see mass health patients. But on average, each one of them saw 2 mass health patients per year. If you were able to convince them to see 10, if all 6,000 dentists saw 10 mass health patients per year, you wouldn't need anything else because it would cover everything. The dentist barriers to entry have to do with time and money. That's what it comes down to. How much time is it going to take for me to do this, and am I going to be compensated so I don't take a loss? The training has to be a reorientation, I believe, in the institutions. We need more mentors and more examples of the fact that you can make a living in public health. Or we need to have examples that say that you can go into private practice, but you also have an obligation so that you can have a combination of public health and private practice and actually demonstrate to people how to do that. We need to make sure that when students come into school, these students are extremely bright, but we're not challenging them to think anymore. We're just continuing to perpetuate the status quo. We need to say to them, here's the problems. With what you know and what you're being exposed to, can you come up with innovative ideas to solve these issues going forward? And will you commit to incorporating those ideas when you practice? Many students come to me and say, you know, I love public health, but I'm going to be a specialist. And I'm saying, so what? They're thinking about it from the context that they can't do both. When I ask students, why did you choose dentistry? They chose dentistry because they watched a mentor. They stood over someone, they watched them, they thought working with people, working with your hands, that's what I want to do. But we need to take them from day one and say, no, you need to change your perspective and open up and become a little bit more broad-minded, that dentistry is not just drilling and filling teeth, but is working with people. And if you chose this profession to work on people, then we have an obligation to care for all people. When you see the clinics that are being done by this guy, I don't know what his name is, out of Tennessee, and he does these auditorium kind of things. The greatest need when he was in Oakland and San Francisco and LA was dental. And they didn't think California had the problems that he had in Tennessee and other places, but it's the same globally. So this whole idea of integration and cross-training so that we all pick up the value. If oral cancer is on the rise, and if seniors come in to see a medical doctor 6 times a year on average, that physician needs to be looking in that mouth and saying, I recognize that something unusual is going on here, and make the proper referral. And what we're trying to say, at least to our residents, that you need to do a medical interview on your dental patients to establish rapport and understand more about their total health before you can really do the best job in treating their oral health. But it is a huge problem. And organized dentistry is perpetuating the economic model. But in our institutions is our best place for making the change.
And to your point, Zola, I mean, that's probably the most common question of how do you get dentists to take Medicaid, in short. But that's mostly the kids of color, the coverage they have. And with ACA, we're going to see even more children coming into that pipeline. And so what's starting to happen, and maybe Brian, you could comment on this, are two things. Some states, if they have the legislative courage, are actually raising Medicaid rates a little bit. And that seems to have helped in Connecticut and a few other states. But what has been the third rail are change of scope of practice. So can you find this alternate provider model to provide this care? Dental therapist, dental hygienist. Can there be a team where a dentist is part of the team, but they don't have to see every Medicaid patient? You can have a dental hygienist or the dental therapist. And for those of you that are familiar with some of the battles that have been going on in Alaska, that's exactly what that battle is about, where essentially you have a huge population that needs good oral health,
Right.
but there's no dentist willing to go up there. But at the same time, nothing personal.
No.
They need the care. But they're fighting the fact of creating this dental therapist to be able to do that. So I think that's at the heart of this issue, because
Okay.
to Tam's point, by the time, you're right, by the time we change the culture and change the curriculum and expose the dental students,
Absolutely.
we're talking 10, 15 years down the line. 2014, the floodgates are going to open with all these Medicaid kids coming in the system.
Well,
So
I
what
think-
are we going to do?
Yeah, and I'm glad you brought that up too, because just to expand on that, there's only 2 states that have dental therapists. So dental therapist is equivalent to a nurse practitioner. Now, this state allows dental hygienists to work under the supervision of a dentist, but to be able to work off-site. So there are programs that are being instituted now with dental hygienists are going into elder care services and providing services. Cambridge Health Alliance, we have one who's starting to do that. They report to us. We can get into issues where it's beyond their scope, but the dental hygienist can actually go out and work independently, but connected. The dental therapist or the dental therapist mid-level provider is a huge issue in dentistry. It is causing wars in dentistry. The folks in Alaska created somebody that was trained in the Scandinavian countries, because this is a Scandinavian model. And the training would allow them in a shorter period of time to come back and administer dental services for children. The state of Minnesota is the only state right now in the lower continental 48 states, or whatever it is, that is training dental therapists right now, and their first class to graduate would be this year. Now, they have a model that takes students who qualify right out of high school, as in most countries of the world, and they're training them to be and give them a bachelor's in dental training. So they can actually go out under the dentist's supervision and work in underserved communities for less money. Then they have dental hygienists that are coming into that program, and they're getting a master's. So it's a 5-year program and a 4-year program.
Thanks, Brian.
Rod, could I add something?
Yeah, go ahead, Octavio, and then there's a question over
Because
here.
it brings up the same thing with in mental health. But the other area that's really being hit hard is the fact that we're not creating enough primary care providers. So we don't have enough oral physicians. We don't have enough those in behavioral health and obviously in primary care. Why? Because we have an infrastructure that is dedicated to really creating specialists. We're great at that. The United States creates more specialists than anyone else on the planet. It was we had an initiative to increase primary care, and we had a good bump. It went up to about 2006, but since then the slope has been negative, so we weren't able to sustain that. But why? Because in my opinion, we did not change the underlying infrastructure, especially the financial incentives that really ask you what happens when you're in medical school or dental school or any other psychology, and then you move on to into your clinical settings. And the whole system currently reinforces moving into more primary care in general. And so that in itself, I think, is really a big challenge. As pointed out, there's no way we're going to be able to create what we need in this country by 2014 from a workforce standpoint. So as Brian's pointed out, and I'd like to add, we're having to think out of the box. And in psychiatry and behavioral health, one of the things we're thinking about is peer support specialists. And in fact, in Texas, what the Hogg Foundation, part of the Department of State Health Services, has developed is an entity called Via Hope. Via Hope is a peer support specialist training technical center. And so these individuals, so what's a peer support specialist for those of you who may not be aware of who they are? They're individuals who in fact have been there, done that. And what I mean by that is in fact, they're individuals that have recovered from either substance use, which is where peer support really sort of grew from, but now encompasses not only chronic illnesses, but also mental illness. So if someone had depression and they've now recovered. What we also want to change is the whole paradigm to think about recovery, which is the fact the illness does not define you, nor does it determine nor preclude what your future is. With the appropriate interventions, the appropriate therapies, and with partnering with the patient, because the patient brings a lot to that dyad of therapy, is in fact that they can go back to work. They can have a fulfilling life. Now, it's different levels depending on how severe the illness may be. But a peer support specialist is someone who's actually recovered. Now, what we're doing in the state of Texas is we've actually trained them to get certified. That is a step that we wanted to do. Why? Because we know that if we can now work with Medicaid and with Department of State Health Services to also now get them a reimbursement code, then they actually can get employed. And they're like the patient navigator. That's another term, promotora, community health worker. All those can fall under the rubric of someone who can actually be certified and specialized. So they not only can help with oral and behavioral, but in fact they can help in chronic disease. And obviously with a comorbidity that affects all the things we're talking about. So that is a concept we're pushing in Texas. It's a pilot project we have in Texas that's moving forward. And we're trying to address some of those barriers like Tam mentioned, especially financial reimbursement. But those are, now, this is not being completely taken, sort of like with open arms by my colleagues, as you can imagine. Because the truth is, or by psychiatrists in general, or other specialists.
Right.
Because they're, the guilds, they hold on to their definition and our stature and how much money we make. So there's all these dynamics come into place. But the truth is then, okay, if you don't exist, literally, in counties in Texas, who is going to provide the care? We're having to think out of the box. And we're going to have to look to allied health. We're going to have to bring in our nursing folks, bring in schools of social work, bring in schools of psychology. All of us really being integrated and working together and actually being seen as the team can really provide the care. And it's not just going to always be the doc.
Right.
So I just wanted to add that because Brian really brought that point to it.
That's a great point. And hopefully if ACA stays in place, a lot of support and funding is to help support the growth of these allied health workers, community health workers, peer support specialists, et cetera.
Exactly.
So let's keep our fingers crossed on that. There was a question or so over here. I don't know.
A couple over there.
Oh, yes, over there in the back.
I just want to say thank you so much for this conversation because I am from Fresno, California, and we have 96 languages in our school system, and we've just been identified as not the poorest, the next to the poorest region in the country. And so thinking outside of the box is not only something that we need, but unfortunately is almost something that's new to the consciousness of that region. Because even having a regional approach is not something we've done well. It's a pretty high ag population with, owns the money. The same day that we were identified as being the poorest part of the United States, they gave a $25 million tax bonus or, whatever that they did to the farmers. So it's very hard to break through these social structures that inhibit an out-of-the-box kind of thinking. So I'd be interested in knowing where have we had success in getting allied health kinds of services so that they can we actually have a teaching hospital where I am, which is great, but it's still breaking through the way they think. I'm just kind of concerned about waiting another 30 years before we're able to see some kind of impact.
Yeah,
so I don't know if you can speak more to that. Thank you.
Great question. A lot of this involves change, and the old phrase, I'm all for change as long as you don't change me.
Right.
So any thoughts on that? Because we really are talking about how to push that boundary and doing it in an accelerated fashion. So
let me add something that's going on in Texas that kind of speaks to that, because you're so right, and that's a really astute observation. And it's just not in California, it's definitely the rest of the country, and especially in states like Texas. As you well know, our governor is not definitely in favor of the Medicaid, expansion.
Oh, really?
Yeah, really. And he's holding to that. How long he'll be able to hold will be interesting. Now, the reason I'm bringing that up is because, one, because it was brought up yesterday in Medicaid. Medicaid in Texas is the criteria, as they pointed, about the 26% of federal poverty. So you got to be extremely, economically impaired. But it's only for the elderly, either the dual eligibles, and only for pregnant women and children. Right, Tim?
That's right.
So think about everybody else in the middle.
Yeah.
Hence the reason we have the highest rate of uninsured in the state of Texas. They don't get covered at all. You're on your own. Truly, that pioneer mentality and pull yourself up by the bootstraps, which, as we've discussed, that doesn't exist for anybody. We all rely on each other some way or some fashion. So, what our commissioner for the health did, as well as the commissioner for health services, they go is, okay, we're not going to be able to expand that. That's not what the governor wants. But what they put in was for an 1115 Medicaid waiver. Now, what's interesting about that is going to Medicaid directly and saying, can we do things differently? And what we're doing in the state of Texas now is actually doing our own version of the ACA. And what I mean by that is they've portioned up Texas into 20 health partnerships. So geographically, 20 areas. Within the 20 areas, each of the areas has an anchor. It could be an academic center, it could be a hospital district, it could be a medical school, things of that nature. Within that district, what has to happen now, because we're going to change the way that we actually are going to deliver financially the Medicaid dollars in the state of Texas, is that the entire area within that RHP has to work together. So somebody's actually stepping back, the anchor, and looking at the big picture finally. Because what's going to really come into play, and why Texas is really interested in doing this, the intergovernmental transfers. So you can get a match if you have tax dollars that the state's putting in. Which are the ones it has to be at that level? It has to be taxing from the individuals, right? By doing IGT and by doing a regional health partnership, we're actually able to go to community mental health centers who are getting tax dollars from the state of Texas, or maybe the county hospital district was getting tax dollars from its catchment area, and those are actually going to qualify, which haven't before in the state of Texas, to actually get a match. It's actually going to increase the number of dollars in Medicaid for the state of Texas. Now, probably shouldn't say this, but I know that the governor's office wasn't very pleased that they came up with a solution that kind of was an end around. But the truth is, the need is so great out there that the Department of Health State Services knew that they had to do something for the people of Texas. So this is going to be one way, because what's happening now, in reference to that, is within each of those RHPs, there are academic medical centers, and they're being at the table and they're being forced to think, how are we going to create the workforce? How do we change curriculum? What kind of clinical experiences must they have to create the workforce that's going to go now into these new sort of integrated approaches, as they're referring to it. Integrated, separate from the term we use for integrated healthcare. But the great thing is, at these 1115 Summit, I was there presenting, and it's front and center, it finally is actually behavioral health and oral health is being discussed, which hadn't even been at the table for discussion. So it's just to give you an idea that there's a way to sometimes do things and to move it forward. But the devil's in the details, and a lot of people are worried, especially the private hospitals, because they're wondering how are they going to get their reimbursement for the uncompensated care that they're delivering. Yeah. But they're having to think about this as well. And with that, I know Tam has some comments.
It actually was to add to that, with the 1115 waiver, just to give you an idea, so for every dollar that's sent up, $1.40 comes down, so people are able to actually double their money almost coming down. And in that, a big part of it are these delivery service re-engineering kind of projects that are able to come about. And what qualifies, actually for one of the categories is actually care delivery expansion. So the ability to be able to subcontract with providers like community health centers, like school-based centers, et cetera, is really the opportunity for enhancing and expanding that care delivery. So one of the things we're looking at is in one county where we are, where there's absolutely nothing. There are no psychiatrists, there are no therapists to take care of kids, and there are like, I don't know, a ridiculous amount of schools, like 168 schools, and the dearth of pediatric providers and adult providers to take care of them. We're using one of those disparate type of projects and initiatives to say, okay, we're going to do school, we call them affiliated centers, which really is serving the community and embedding a mid-level family type nurse practitioner with a therapist so that we can actually expand that service delivery, kind of a hub and spoke type of deal so that we can actually take care of more kids. And then leveraging virtual care, which is something that we hadn't really had an opportunity to talk about, but is huge. And the challenge that we have as a community health center, we can't get reimbursed for it. Yeah, I know the environment is different in different places, but really I think there's literally money in it, for those entities that can deliver it, and the technology is there. So I think that's another ground of opportunity as well.
And I just add, I know we don't want to take too much time with this, but what's also interesting and what's helping us to address this is not only has to be innovative, as Tam said, because what they've done is they separated it to two pools. 50% of the money is going to be coming from Medicaid and with the match to be delivered to the RHPs. Half will go for uncompensated care as it's been done normally. The other half, to achieve it though and to receive it, has to be innovative, and there have to be outcomes and metrics that are currently being developed to be able to receive those very dollars. So it's another way to actually push the agenda.
And I think, building on that, we often talk about the DLP, the Disparities Leadership Program, that these systems are very hard to change because they're entrenched. And the only way to get past it is building a critical sense of urgency. Mm-hmm. And sometimes that sense of urgency is the health problem need, and sometimes it's economic. So for many states, although there's the rhetoric that, we won't take Medicaid dollars, many of these states are leaving billions of dollars on the table.
Absolutely.
And that's enough of a sense of urgency to get people to start to do things and change the systems that you're referring to. So I know there's a question here also.
Good morning.
Good morning.
I'm Frank Robinson. I'm from Springfield, Massachusetts. And I started out with a question, but I think Tamarah answered it for me. So I'm going to make a statement and then ask my question to see if I got it right. In Springfield, we developed an alternative care system to deliver oral health care to preschool-age children by embedding that service in preschool settings, such that the preschool becomes a comprehensive service for the child. They get total dental hygiene services, fluoride varnish treatments, and then the dentist team sets up on-site and embeds their services through offering dental services using portable equipment. And that model works for thousands of kids every day, forever. And it's sustainable. So we installed it. We have been out of those preschool settings for over 5 years, and the service continues without us, because once you fix it in and set it up, the reimbursable services that they deliver are covered through Mass Health and private dental insurance. The front-end cost of building the system is what's a challenge, and then to being able to offer it scaled up such that it is, in fact, a working concern for the dental teams and the hygienists that are working there. So that's the model. It depends an awful lot on partnerships and collaborations and sort of an overall collective approach to serving it. So it's more than dental care or oral health care. It's really a community care system, if you will, or an alternative care system, dental care system for our youngest. The piece on that is that we started with our youngest because nobody wanted to see the 1-year-old or the 2-year-old or the 3-year-old for a lot of reasons aside from the fact that they had Mass Health. Our aim is to try and develop that kind of embedded service or alternative care delivery system for whole child health, such that children get behavioral health, oral health, vision, hearing, screening, all the stuff that normally you would expect they would be getting through primary care systems, but somehow that doesn't happen routinely. And so we're trying to figure out how do we do that using the same approach, embedding those delivery systems in some of those already established organizations. And so what I heard from Tamarah was this affiliate sites where there's, so I think, did you answer my question, or is there more to it?
Or just this stuff?
I think so. I mean, our approach was really going to schools, either in schools, themselves, where that school district will allow, or actually developing sites that are really proximal to schools so that you can capture that young population. They don't have to necessarily leave the campus, to be able to go, but it also serves as a portal for the rest of the family, adults, even those who are taking care of the kids during the course of the day, and provide those services. But it's exactly that, being able to embed a medical behavioral health team right there. We haven't launched into the oral health part of it yet, But that is the idea, and so that pairing will happen. Right now, we're doing some work in behavioral health embedding right now in the Austin Independent School District, and it's really improving morbidity quite a bit. They're also seeing families, there and doing group therapy. We're wanting to tap into the medical part of it in those schools as well, but that's been a little tense in being able to do, but that's the vision. So I do think you're on the right track in doing. I'm going to steal that with preschools. That's brilliant.
Yeah,
that is good.
there's been a number of folks around the country doing similar kind of things. Not many, but a similar kind of idea of actually trying to capture the Head Start programs.
Right.
And actually, many of the Head Start programs have hundreds, sometimes thousands of nurses that are attached to
Right.
it. And if there's a
Right.
way to leverage them either for oral health, to kind of do some preliminary screening, or even sealants, et cetera. So there's a lot of talk about how do you actually go further upstream using the preschool populations. But even here in Massachusetts, there's been interesting work around embedding mental health services in school-based systems. And I'm hearing more and more of that. And it's clearly showing that it's having some impact. So I think, to your point, Frank, hopefully the challenge is trying to connect these two systems, because when I talk to folks that do this work, the biggest challenge is trying to get the education folks on the same page as the health folks.
Right.
Because the agendas are so different, the language is so different. Just like docs, teachers feel like they don't have time for this.
That's right.
So there's this collaborative process that needs to go on to figure out how do you link, say, the educational window with the health window to best capture some of these populations.
And Rod, I'd add that also the model that that fits in with, his name's Frank?
Yes, Frank.
Frank, that you brought up is systems of care. And so you're bringing different systems and institutions together to deal on that. And where it also really ties in, especially also with the mental health of children, is really the cradle to prison pipeline. And so if you're able to make that connection, and especially if you can also financially show how, in fact, investments today are going to prevent these kids getting into the juvenile justice system. Because in Texas, that has actually resonated because of the immense expense it takes to actually, when a child does go in the juvenile justice system, and then the sequelae that then there happens, and how then they are, that cost to the state of Texas is much greater when we invest in their health and obviously in their education.
That's a great point. There's a question over here, actually two, so this will probably be our last two. Thanks. Might ask you guys to just keep it brief, because I got my 1 minute warning.
Gotcha.
So.
I appreciate this conversation, because I think that the forming partnerships with these other systems is where we need to be going. We do have a partnership in Allentown, our health system, with our school districts in providing school-based dental sealant programs, which has a long history of evidence behind it, as do community health worker programs. And one of the things that I haven't heard discussed is, we kind of touched on partnering with public health folks, public health systems, local health departments or regional health departments, but I haven't heard a lot of discussion about community-based organizations. And certainly community-based organizations, they have a wealth of experience, many of them do, with community health workers, which I'm a strong advocate of. So I love the fact that you brought it up and you're talking about it, and it's happening in some areas. But I guess one concern I have that I'm hearing, and my background is in public health, but I'm in a healthcare facility now, is healthcare now kind of taking all of these things away from CBOs rather than partnering with them. So we're bringing them into our house now, and you don't have them anymore, and they're struggling. And so how can we form partnerships with existing CBOs rather than eating them up because we have better resources?
Yeah, great point. Comments?
I think, that's a great question, and I would say absolutely not. The short answer is that I don't think that that's happening, that in terms of healthcare entities wanting to really bring all that in. I think there is a recognition that we need to have all these pieces. So if anything, we're actually facilitating more glue so that, the continuum is there. I think about relationships we have with housing authority programs in the area, and they need to provide mental health and physical health for their clients that they're taking care of. So that's a natural alignment, and we were glad to take that. It's like if you're taking care of the housing and some of their nutritional needs, perfect. We'll do the mental and physical health, and we'll make sure to communicate. That's our promise. To be able to do that. I think though that's an interesting point that you raised, because it's really about where the money is flowing. And I think our challenge in our tax is really devolving the solar system. Whereby where the physicians are not the sun and everybody else is the planets, but it really is a solar system where we're all kind of orbiting all over the place, and together we make a solar system type of a thing. But it's a great point that we have to continue to remember. But I would say absolutely not. It's really more.
I'll add one thing to
Yeah,
that,
go ahead,
Rod. Tam, I think, had a great answer. What I would also add, as I was listening to her answer, is the world of philanthropy can be your partner here. So find someone that's a local organization,
point.
sort of like the Hogg Foundation, and we're seen as being sort of, we're not
You're neutral.
partisan, we're
Yeah.
neutral,
Yeah.
and so they can be a great partner in the sense they can bring the people to the table to have the very dialogue and discussion that needs to happen.
Yeah.
We've been providing that role in the state of Texas, and it really does work and it really does help.
Yes.
Because even though maybe healthcare organizations don't want to take over the CBOs, there's the perception. And if you don't bring it out to be an elephant in the room and just have the discussion, and it was one of the very first things we did when it came to the FQHCs and the community health centers. Each thought their dollars were going to be taken away
Right.
with what they saw happening in the changes in Texas. What did the Hogg Foundation do? We just brought them to the table. We'll serve lunch. It's like any conference, food will bring people.
That's right.
And let them talk and just
Yeah.
let them hash it out. And it took a year, but they're at a good place now.
Yeah.
Actually, thanks to the Hogg Foundation, we actually have a great opportunity where we're partnering with one of the local mental health authorities where they're looking to do better transition of their patients that they're going out that are eventually coming to us. So we're embedding a provider into their system to actually facilitate that so they have medicines. We know their history. There isn't this fragmentation of care. So we're very appreciative for that kind of opportunity.
And at the core of your question, and from their tidbit, what's really forcing this transitional point, as I mentioned at the beginning about healthcare, is forcing people to collaborate. And the interesting thing is most people don't know how to do it. And so their perceptions of, they'll take over my market share, where are my patients going to go? And it's from all sides, from the hospitals, from the health centers, from the CBOs, from the social services side. Everyone is kind of concerned, but it comes from this core that they have to go through this process of figuring out how to collaborate together. And your point is a perfect one, because a neutral convener, whether it be the foundation, whether it be sometimes the government, is a good neutral convener, that it brings people together to have those conversations to figure out how to collaborate. All right, so we run out of time, but Ed, you get the last question.
Okay, this may not be a short one, but anyway.
I know you can do it, Ed.
Okay, yes, okay. I just wanted to comment, it's a more systemic question. I just wanted to comment on the fact that our penal system in the U.S. has become the default mental health system. And of course, the overwhelming number of the penal system is populated by people of color, minorities. And do you see a change, or is there a conversation as to how to move this out of the penal system and have care where it should be done?
Great question. Octavio?
We're having that discussion. Ed, that's an excellent point. As a matter of fact, I'll add to Ed's comments that if you take a look at the 1890s during the time of Dorothea Dix and the rate of incarceration that was happening there, it's a U-curve. We're now back to that same amount of incarceration. So really the criminalization of mental illness is back to the level of the 1890s. It is horrible. What we're doing in the state of Texas and how we're sort of addressing that and how the Hogg Foundation is trying to make sure that stays on the agenda, Ed, is we're coming in from the financial aspect. One of our biggest partners in the last legislative session was the Texas Sheriff's Association. Who would have thought they were going to be partnering with mental health, because they're getting hit with having to transport individuals that are needing mental health services, and so they're under protective custody. And you get these little communities out there that has a sheriff and just 2 deputies, and one has to travel halfway across Texas to go to a facility because there's no one anywhere near them. So we're able to get them to the table and understand now the impact of that. If you decrease public mental health services, there are other systems in Texas that are paying the price. And so one of the things that we've come up with, small, but it's a movement in the right direction, is actually community-based outpatient restoration for those individuals that are considered to be incompetent to stand trial. And so instead of now actually for them being either incarcerated for a long period of time or at a state mental hospital bed, where it's extremely expensive, both those areas to care for folks, we've actually been able to partner with and have on the books, and now we have an outpatient restoration to be able to handle that. Very small little piece, but it keeps it on the agenda, and it's able to discuss that very issue.
Great.
And also that cradle to prison pipeline.
Yep.
So we're able to also partner with the educational system because they understand how this happens. And also, I know that Leave No Child Left Behind in concept was very good, but what's happening in schools in Texas is, in fact, any disruption, there's zero tolerance. And where does that young person go? And overwhelmingly, it's children of color. They end up getting sent to the principal, or they end up actually being given a ticket, literally a ticket. And then the parent can't pay for it, and now there's actually someone looking to incarcerate the parent or the child. So there's unknown consequences to some of these laws that we need to be flexible in and we need to undo and realize that isn't what was intended, but yet this is what's contributing to the issue.
Right. So we've run out of time, but I want to give you guys 3 words to leave with the audience.
Well, first of all, I would say
3, Brian.
3.
You used it 3 up.
Thank you.
Thank you, Brian.
Just a couple quick comments. That organized dentistry is not going to change unless it gets paid more money. So we have to start somewhere else. And what dentistry has to look at is how we can piggyback with collaborations in terms of funding. You start looking at the nutritional aspects of what's happening orally. You can team up with those kinds of things. So we're looking at obesity, we're looking at nutrition, and how we can work together. And sometimes just dentistry or oral health as a risk factor is a way for us to get in the door. So those types of collaborations relative to funding is how we're going to have to go, because coming straight in from an oral health point of view, you have to orientate so much to get people to understand it that it's almost like reinventing the wheel.
Great. Octavio, 3 words.
Well, it's more like a statement, but I'll try. Don't also forget leadership. And leadership from the grassroots up and from the top roots down, as they say. The leadership that we need in state, the leadership we need from the private sector, the leadership from our world of philanthropy, and the leadership that exists in the community. Bring them together, we can all together really come up with solutions.
Great. Tam, you just say
I'm
whatever
gonna
you want. But
try.
they haven't listened to me, so you just do whatever you want.
Try to be obedient. Vision, having a vision for your organization or yourself as a provider, if that's the case, about seeing an integrated whole care delivery system that has innovation. That's the second word. So not being afraid to try some things, even if the reimbursement doesn't follow or the funding doesn't follow, because sometimes that makes the case for that. And the third is sustainability. We got to think about the future. Because there's only going to be more, not less. Hopefully, if we do a better job with the vision and the innovation part, we can actually do better for the sustainability.
All right. Well, great. Please join me in thanking the panel. I think we had a Twitter question for the group. Thank you. And just as a reminder, guys, please, Lenny's leading the evaluation SWAT team. Please do your evaluations. It's very important to us. It helps us to help constantly improve what we're doing today. And you guys have been great. Thank you. We had a great time. Hopefully you found it helpful. And I'm going to turn it over to Joe, who will kind of wrap up some comments before we head out to lunch. So thank you, guys.
Okay, great. Thank you. Wonderful morning. Hopefully you all found it interesting. And I think some wonderful points made. HIT and the areas of oral health, mental health, and integration, really new areas, I think, that are growing rapidly. Couple of quick things here. Number one, there is information in your packets about how to log on to Twitter if you're having problems or how to respond. But if not, Daniel is our assigned expert. Daniel, why don't you stand up? Daniel is going to help anybody with your responses. The only thing you can't do is say, hey, Daniel, can you say A for me on number 6? So we're going to ask you to go ahead and do that. Again, evaluations are key. We're going to be moving to lunch in just a couple of minutes where we'll be similar to yesterday. We'll get seated, and then we're going to do a session on messaging and communication, which I think will be really interesting given everything we heard yesterday. The one thing, if you'll allow me, I just wanted to mention is that this is our first time doing a large conference. However, we have been doing something called the Disparities Leadership Program now we're into our 6th year. Disparities Leadership Program is a 1-year education program, 2 face-to-face meetings, distance learning mostly, and it's a way where we engage teams from hospitals, health plans, and health centers to come together in a cohort, usually about 15 organizations a year, to come together, agree to advance some aspect of a project at their home institutions forward over the course of that year. And we provide training on, what are disparities and all the things you heard today, but in a much more intense way, and you're part of a collaborative, more than several, but a large handful of you have participated in the Disparities Leadership Program. So I just urge you to consider participation in that program. And we wanted to just, if you want to pop this on, this has some of the statistics around the program and some interesting visuals which you think will take us out of this session nicely. Again, I want to make sure that you understand the forum is different than the DLP. The DLP is a little more intense. We will hope to do this forum every year and constantly be changing and really pushing, trying to groundbreak every year that we can. So thanks so much, and after this, we'll just head out to lunch.